leave my video on and you leave your video on. Good day, everybody. Just so that you know, we are recording. So if you're not happy to be on the recording, please sign off now. But otherwise, we are recording as we go. And JG, just to answer your question, I put you on the speaker so that I can only get to see you. So if you want, you can do whatever you want to do. The recording just shows you. So that's why I do it that way. And then everyone else joins that way. So to start off with, let me explain to you my belief systems, JG. Number one, I firmly believe that health is more than what you eat or drink, whether you exercise or whether you avoid certain food items. I firmly believe that health is diverse, dynamic, and deliberate. I firmly believe that health is not possible under the hand of only one practitioner, one discipline of medicine or healthcare. I firmly believe that health is a person's primary responsibility and must be person-specific. I firmly believe that health must be conversed on a physical, chemical, emotional, mental, spiritual, cultural, racial, and various other undetermined levels. And I firmly believe that there must be a better way than what is our current status quo. So with that being said, JG, I hand over to you. Your educational background, I think, is worth discussing first. So how did you become a data analyst in the healthcare industry?
Sure, Travis. Yeah, great an opportunity to just share with you and the folks that are on the podcast this evening. So cool, exciting question in terms of how I became a data engineer in the healthcare industry. It starts off with the healthcare industry. So by training, I'm an electronic engineer. And then I went on to specialize in biomedical engineering. Many years ago, it was only offered by one facility or one faculty, and that was at UCT. And I actually chose I chose my university based on the fact that they offered that as a postgraduate degree. And so got going, specialized in electronic engineering, and then did my undergraduate thesis in biomedical engineering. It was a fascinating project where it was working out some mathematical models of the lung, and got sufficiently excited to pursue biomedical engineering. And biomedical engineering is an interesting, I'm going to call it a sport, because it has multiple pieces to it. You know, literally, it's a bit of a privilege to come off the back of a very strong engineering type degree, very technical, very focused on mathematics, very focused on technology, and then come straight slap bang into studying the body. And I call it a privilege mainly because, I mean, it is exactly that. Is the body is an incredibly it's an incredible thing to study, particularly as an engineer, with the curiosity of an engineer. And with my electronic background, it was I quickly specialized in ultrasound. So my speciality through my biomedical engineering degree was ultrasound. And I mean, maybe I can just try and make this real for you and the people on the podcast, Travis, is, you know, as a medical engineer, we started our biomedical course studying with doctors, and you basically entered in at first and second year level of medical tuition. And you know, as an engineer sitting there learning about the anatomy of, for example, the hand. I mean, just to make it practical for the parties on the podcast is, you know, if you just have a look at your hand as it stands right now, and you maybe sit with your palm facing up, I don't know whether anybody's ever wondered how on planet Earth is it that your top digit, so the little piece of your finger, any one of your fingers, the little top piece, your finger's divided in three, let's call the top piece the top digit. How can that guy work independently of the other parts of the finger? You know, so as people are sitting on this podcast, I encourage you to just look at your hand and try and flex the top part of your finger. And then you go, well, okay, cool. Imagine I now want to flex two of the top parts of my finger, exactly like that, Travis. Now, from a mechanical engineering perspective, if you have any background in levers, you'll go, oh, shucks, where's the fulcrum that's resulting in the resultant force that allows a single digit to work independently of the others? So when you're a medical student, it's amazing, and you're figuring out how the finger works. But when you're an engineering student, you go, oh shucks, how does that work? And then to be blessed with the privilege of doing anatomy, and now you're dissecting the hand, and you realize that actually there's a tendon that runs through the hand into the finger, and then it splits in the most glamorous way, and it runs each of the digits, and you go, oh, that's cool. And then you go,
yes, so certainly, JG, when you're talking about this, you understand my world. So, as a young kid, I observed movement because I'm ADD. And then when I started to study anatomy and physiology from a biomechanical point of view, with the things that you mentioned, for me was so profound. And as you said, the orchestration of the body is unbelievable, and it often defies laws of gravity, as an engineer would have known. But you spoke about ultrasound. So tell me, are we talking about ultrasound as in skeletal ultrasound, as in diagnostic ultrasound? What are we talking about there?
So predominantly diagnostic ultrasound. So because I had an electrical engineering background, some of the really cool stuff that comes with ultrasound is ultrasound imaging, and in particular Doppler. So the word Doppler, you might be familiar with it, but it's got to do with it. All it does is it figures out what direction things are moving in. And it's used all the way from the stars, the redshift of the galaxies, all the way down to the Doppler, any lady who's needed to go for an examination of a baby would know that you use ultrasound to do the imaging. But my speciality was we used ultrasound to figure out the pulsatility of the blood flow that was flowing through the umbilical arteries and veins of the baby.
Sure.
And so a couple of years ago, I'm going to age myself, I'm just going to say a couple, right?
Right.
So the diagnostic method of determining fetal distress was intrinsically, you looked at the heartbeat of the fetus, and based on the heartbeat of the fetus, you would then diagnose that the fetus is in distress. And then there's no better place for a baby to be than in its mom's womb until the baby's not getting any oxygen or food, and then it's the worst place. So there's this magic moment of when do you deliver the baby? Like as a clinician, how can you be supported to know when's the best time to deliver the fetus? And for many years, the overarching diagnostic technique was to look at the heart rate. The problem is the heart rate was a lagging indicator of fetal compromise, of the fetal's health, when I say fetal, the baby's health. And so, I worked with an incredible clinician. I was a student. I would cycle through to the hospital at 3 o'clock in the morning, and we would deliver a baby together. The challenge was a lot of these babies were being delivered and not living very long. They were very small. They were growth impaired. And so the question that was asked is, if one were to administer oxygen to the mother during the course of her pregnancy, does that have a positive effect on the outcome of the baby? And for that, we needed a much more sensitive mechanism of measuring the way in which the baby was responding to the stimuli, be they even if they weren't ill. And quickly what we realized is monitoring the heart rate was good, but it's too late. When the heart rate starts to decline, the baby is in distress, and you don't have enough time to get them out. So what we realized is the pulsatility, the what's the right word for that? You can think of it as the bounciness of the waveform that gets made in the umbilical artery turns out to be, well, actually the umbilical vein turns out to be one of the best ways of determining the state of the fetus. And being an ultrasound specialist, I partnered with this doctor, and we prepared several papers with respect to how one would go about using fetal ultrasound of the umbilical vein and artery complex to determine whether the baby should or shouldn't be delivered.
I'm going to interrupt you at that
oxygen.
point, JG, if you don't mind. I mean, what you're saying to me makes a lot of sense in terms of understanding the specific nature of something that then determines a course of care or a course of treatment, or what you do next. And certainly from a clinical practice point of view, that's obviously a really difficult answer. And when we were studying, we got taught about the gold standard. And so I think it's really important for the people on the course on the call to understand the concept of a gold standard. And so when we set something as a gold standard, it is the most effective method of knowing something, which will then alter the course of treatment or care. It would be I don't know if you have a thought on it, but it'd be interesting to see in clinical practice how much, because I know my answer for my clinical practice, I don't necessarily go with what's the gold standard because of, time and money and all of those things. But how often in clinical practice are we making the decisions on what is the gold standard versus how much we're making that decision based on something else?
Yeah, Dr. T, I guess one of the things that maybe not answering your question directly, but it's got to do with this trade-off and compromise. I'll never forget the clinician. His name was Dr. Jerry Mantell, amazing man. And he would spend so much time with the mom explaining that the fetus has some challenges. And he almost felt responsible to figure out when's the best time, when's the greatest opportunity to give the baby the best chance at life. And you could just see here, there I was. I mean, I mentioned many times these deliveries were happening in the dead of night. Nothing else was happening around us. And you could just see him deliberating in terms of should he deliver, shouldn't he deliver? And then to have assisted him in that, to give him another input as to inform that decision. Sometimes a clinical decision is not a clear-cut answer of the gold standard, the best way. It's got to do with the mom, the baby, the situation, the circumstance. And I guess that was kind of one of those real energizing moments when you realize that some of your work has participated in being of assistance to a clinician who is in that moment trying to figure out, do we deliver the baby? Because remember, some of these babies are prem, they're coming out 1 kilogram, 1.3
Sure.
kilograms. I mean, they really are small and they're going to fight for their lives. But at what point do I offer them the chance to fight for their lives versus, oh shucks, I wasn't brave enough and they didn't have a chance to fight for their lives.
Sure.
So that was how I.
But I think what you've given me now, which is an important part about being a clinician, and for me, the people on the call, most of them are patients of some sort, and even myself, when I go to see a doctor, I'm a patient, even though I'm a chiropractor, and when I go to the doctor, how much the doctor is factoring these conversations in place in order to make what is the best clinical decision. And particularly, when there is a lot at stake, as you're mentioning, from delivering a baby that's 1 kilogram to a baby that's 1.2 kilograms, it makes a massive difference in whether that baby survives or not. I don't want to harp too much on this because I want to try and get you a little bit further. So from there, how did you get to becoming where you are now?
Cool. So I guess I give you this preamble purely because when I say that healthcare is emotive, I'm going to ask you to reflect back on this discussion we've just had. Is that healthcare is seldom a cut or dry thing. It is emotive, and invariably it depends on a lot of opinion. And sometimes it's the opinion of the patient, opinion of the clinician, opinion of the environment in which the patient finds themselves. So I lay down this foundation to say that this is my preamble to entering into healthcare, and in particular healthcare, and in particular the data side of healthcare. So how do I find myself in data? I go through my data background actually came through some supply chain work that I did, and then the company that I worked with said, JG, we've got this opportunity. It's a medical. It is a pharmaceutical distributor to distribute pharmaceutical product, and it would be really helpful for us to have oversight at a country level in terms of what drugs are where and how does what's the movement of pharmaceutical product around the country, and where does that basically just give us a sense of, from a commercial perspective, as to where our pharmaceutical product is. I pursued that for a long time. We did some really good work, worked with great people, and put together incredible data platforms that informed all parties, both doctor and pharmaceutical companies, where the product was, how long has it been there. Because remember, pharmaceutical product or healthcare product has got this constraint of time. All products have, you need to know where they are. Some of them are temperature sensitive, some of them are time sensitive. So I have a very strong kind of background in pharmaceutical product analytics. And then I specialized in medical device diagnostics. And that's now, no longer are you dealing with high volumes of product. You're now dealing with low volumes of product, but very specialized equipment. For example, a stent. So if somebody has an aortic aneurysm, which that's another way of saying that just there's a big vessel in your chest, and if that thing has to bubble out or, heaven forbid, rupture, there are companies that produce product that help you to get in there and kind of fix it. It allows you to fix the aorta. So you insert it sometimes through the leg, through inguinal artery, and then you put it into the aorta, and then you can think of it as a mesh, like a wire mesh tube that goes up and it sits, and it kind of reinforces the aorta. The problem is, once again, healthcare is not just emotive, but it's individual. It's incredibly individualistic, and that is like the renal artery, the artery that comes out to feed the kidneys. The size of the stent that you need, well, it all depends on the patient, and sometimes it's really difficult to figure out what you need before you're in the body. So sometimes the doctor only knows once they've done once they've got the thorax open and they're doing heart surgery. Oh my word, I need this size. So all of a sudden it went from the medical data of drugs to the medical data of equipment. We used to call it medical devices that are inserted in the body according to medical standards. And so there again, I think, I learned that healthcare is emotive, and now healthcare is incredibly individualistic. It's an individual. You cannot generalize. If you generalize, be wary of your generalization. And so, that would be a key message that I offer through my learnings of data.
Well, JJ, I think those two mechanisms for me are vitally important in terms of understanding healthcare. And I certainly feel that from my professional background, I try to incorporate both those two aspects. But I think if we can dive into those two aspects for the people on the call and for the recording, when you say healthcare is emotive, what is it that you're meaning? And from a patient's point of view, what should they be looking at, and what should they be expecting in terms of dealing with the practitioner?
Cool, thanks, Travis. So that kind of gives me the segue to talk about when you're a data specialist and you have a healthcare bent, which is kind of what I am. One of the key propositions that I'd like to offer to the audience, and I offer it to myself every day, is healthcare is such a generalized term that it means different things to an individual at different times. For example, if I am undergoing a chronic, if I have chronic conditions, the word chronic means over time. Invariably, I am suffering from a particular ailment, but I do so over time. So I have a chronic ailment and I treat it in a particular way. Usually, periodically, I take a particular drug or I take a particular treatment. And Travis, in your practice, you would see patients with chronic conditions that you treat regularly over time. Now, the emotion around a chronic case is completely different versus the emotion around an acute case. Now, for example, an acute care can range all the way from a medical emergency, where under the auspices of a medical emergency, I actually believe that it's like all hands on deck, anything goes. You're just trying to ensure the survival of the patient. And so all of these aspirations of, naturalness and, I don't believe in drugs. In my opinion, that goes out the window when it comes to acute care. But acute care it's episodic. It happens and then it's over. And that's sometimes a good thing, because sometimes during the course of acute care, the doctor will treat you with some very aggressive drugs. They can be aggressive in terms of being addictive. They can be aggressive in terms of other knock-on side effects. But you know what? You want to give that doctor a hug. They did a great job. They saved your life. They did something. So just under those two aspects, I say the emotion's different. And so I want to encourage the people on the podcast today is that when we think about healthcare, it's quite important to think about healthcare under the conditions in which it's occurring. It's occurring chronically. It's occurring acutely. You do get the following challenge: is you get sometimes an ailment is treated aggressively with an antibiotic, and it shouldn't always be treated with an antibiotic. Sometimes you should just back the body, because Travis, we are, again, from my training as an engineer coming through and just, studying anatomy and histology and physiology and these different aspects, like, oh my word, we have the most resilient system. The challenge with a resilient system is you can abuse it and you won't even know. And then you can abuse it for a long time. And then all of a sudden something will fail. And you all of a sudden believe that the last thing that you did was the reason why it failed. But actually that's not the case. Is we're dealing with a incredibly resilient system. For example, the kidneys, you can lose a kidney and continue to function more than adequately. You can then lose a degree of the next kidney and you're still doing okay. That's the level of resilience that
I want to harp onto something that you just mentioned now. You've made the distinction between chronic and acute. And then you've mentioned about someone can abuse their body for a long period of time without being aware of it. So when they have the first sign of something, the presumption is that is an acute issue. Meanwhile, in my opinion, it is more like a chronic issue, because you have had chronic dysfunction within physiology before the acuteness. So in terms of acute care, that for me is different from acute care with a chronic underpinning.
Yeah.
How does that factor into your model or your conversation now?
No, it is exactly the point, is that when we talk about healthcare, I feel like it's so important to offer each other incredible latitude to know that I come into the discussion potentially having abused some of the resilience that I have in my body, or I actually haven't. I've really looked after my body, but I've now had a I've had an acute episode, and now all of a sudden I'm struggling, and now all of a sudden I need some really aggressive intervention, be that through drugs, or predominantly aggressive intervention is through drugs. So Travis, this construct of resilience and the body's ability to, so it comes down to, well, the body is fundamentally, and I loved your proof statements. I believe the one that really makes sense to me is, I firmly believe that health must be conversed on a physical, chemical, emotional, mental, spiritual, cultural level. Is, if one believes that, it means that we have to offer each other incredible latitude when it comes to recognizing that chemically we're going to respond to different situations in different ways. And so we're now sitting in a situation which we've got an incredibly resilient body, which has handled some of the environmental factors that I've thrown in it. Not all of them great. Some people have doped themselves up when they were younger. Some people are just drinking a storm. Some people only drink smoothies. You've got this incredible range of different contexts that people find themselves in, and the body's resilience, which potentially fails, and it fails in two situations. One is you just take it to the point and it can't handle it anymore. 2, age. 3, I want to introduce the topic, but this topic I have no experience on, but other than that, I know it's real, and that's the construct of mental health. And I feel like it's been highlighted to me during this COVID period that we find ourselves in, is that I don't have a mental model yet for mental model for mental health. I don't have a model for mental health, other than it is incredibly real. Depression is incredibly debilitating. And the problem is it's a silent enemy. It's so difficult for people to relate to. And so I just ask and encourage tolerance of people coming through these type of zones where it's not acute care. Off to the hospital, lots of drugs, lots of intensity, lots of fix, lots of high fives. The person's survived and everything's amazing. There's lots of examples that one can quote with respect to responding to acute care. Chronic care, I think we understand really well, and even the medical aids have got into that setup. But when it comes to the mental health side of things, it's so much. It is difficult to quantify.
Well, I'm going to say to you, from a mental health point of view, it's a completely additional factor that I don't feel that most practitioners know about or understand how it influences. And I'll agree with you, it's a very real issue. What I wanted to question you on, and you're more than welcome to take the Fifth Amendment on this, but you mentioned that you've worked for both a pharmaceutical company as well as a medical device company. How much do you feel that these kind of companies are taking into consideration both the emotive side of healthcare as well as the bio-individuality side of healthcare?
Yeah, so it's a great question. I often describe some interventions as you pitch up to you pitch up to a penknife fight with a bazooka. Sometimes that's what some broad spectrum antibiotics are broad spectrum, and they are not showing any level of resolution. I would say that in some circumstances, that is the best way to treat something. And I would say high five, absolutely. So that drug has its place. And so, Travis, I'm going to answer your question by saying that the pharmaceutical companies have produced product that work really well in specific circumstances. The fact that sometimes those products have found their way into other use cases and are potentially applied in a relatively, unconsidered manner, I do think that happens at times. I do think that a broad spectrum antibiotic has its place, but if one looks at its prevalence, I would say that it probably overstays its welcome in some treatment regimes. However, there is development now for some very boutique drugs which take into account people's genetics, and you can now start to see some real engineering of suitable care within the construct of a person's individual traits. That's encouraging. The problem with that, they become really expensive. Usually they're quite cold chain dependent. So all of a sudden products, have a strong disposition to being reliant on cold chain. That makes them more expensive. It makes the risk of moving them around higher. So I again ask for tolerance of our audience to say, anybody who believes drugs are bad, I ask, consider the context. Anybody who believes that drugs are the only way, I ask them to consider the context. And the context that is always true is that when the body is given the circumstances, the time, and the environment to self-heal, I would back the body more often than I would back any intervention.
Wow, that's a powerful statement, JG.
I'm not talking structurally, because I think there are times when the body can't get itself right structurally, but I'm talking, how often is it that when somebody gets diagnosed with cancer, all of a sudden the way they eat, the way they consider what they put in their mouth is really, they scrutinize it. What needs to be true for us to scrutinize it before we have a life-changing event like cancer or the equivalent? And so I feel like the pharmaceutical companies are given a bad rap, and the pharmaceutical companies also at times monopolize on the unknown. And so I feel like when a person takes a lot higher level of responsibility for their healthcare, two things happen. Number one, they actually want to know what's in the drug. You know that little white envelope? It's a flyer. It's written in English, and it's written quite simply for people to understand what's the active ingredient. And I don't often believe in Google Doctor, but I do think that investigating the active ingredient in a product is quite an interesting thing for you just to know that somebody believes that you should intervene in your own body with this active ingredient. I think it's an empowering process. And I believe that if you read the stuff and you don't understand it, that's a powerful doctor, is when a doctor takes the time to explain to their patient why they think it's a good idea and why they think this product will work well. Because what does it do? The patient who's taken the drug can then become part of the process. Oh, it's working. It had this particular effect, and you know what? I feel a whole lot better. That's awesome. But then what has it done is it's empowered the person to be proactive the next time that the doctor is prescribing. So
JJ, I just want to give you a time check. We've got 7 minutes left, and I'm always impressed of how quickly the time goes. I want to come back to the question that I gave you and maybe try and get some further clarity. So, you know, you talk about the emotive and you talk about the individual specific nature of healthcare, and you've worked for drug companies as well as you've worked for medical device companies. When it gets to those hitting the person, as in they're being prescribed by a doctor to the person, is there data that gives us an indication of how accurately that is prescribed to the patient?
Can I just make sure that I understand the question?
Please.
Is the question I heard you ask, or the question I hear you asking to clarify is there sufficient care taken between the diagnosis and the therapeutic advice that the doctor gives through, if it's drugs? So the doctor is requiring to administer a drug. Am I hearing you correctly? You're saying that are all parties sufficiently help me with what you think is going through the doctor's mind, please?
No, what I'm wanting to find out is you've got a drug that is now explained to the doctor for the doctor to use in certain situations. The doctor's got to make a diagnosis, and then they've got to then utilize the drug or the medical device in the correct manner for what it's been prescribed for. My question is how often is that occurring? The doctor makes the right diagnosis and the doctor is making the right prescription of either the drug or the medical device. Is there data that gives us that answer, or is that, you know, still left to, some other force at play?
You know, Travis, one of the companies that I worked for, we spent a lot of time considering one must understand from a doctor's perspective that there are two things that are happening. Number one is that there's a patient who needs their care. And number two is that there is a person who's paying for the care, and it usually is not the patient, it's the patient's medical aid. So you've got this triangle of accountability. The one thing that in our opinion, or in my opinion, that I've seen over and over again, is when a doctor is administering a drug to a patient, they are completely engaged. They are really paying proper attention to what the patient needs and what the doctor is prescribing. And every now and then, the doctor doesn't have the luxury of having a drug exactly what they need. Sometimes you get the combination of, you know, some of them have an, pain plus and anti-inflammatory, some are only an anti-inflammatory and so on. So when the doctor is diagnosing, in my opinion, the doctor is completely focused on that diagnosis. We have the most incredible doctors in this country who care about their patients. Where it becomes tricky is, does the medical record that results as a result of the engagement with the doctor accurately portray what happened there? because now you've got two things. You've got it's called ICD coding. It's a diagnostic coding, and you get a procedure. You get a particular procedure that was performed. And now the combination of your diagnostic coding along with your procedure forms the auspices and the basis against which a particular medical engagement is billed. And now all of a sudden you have a challenge that's been there for a long time. You have a data asymmetry. You have the insurers, which are data rich, and you have the providers, which are data poor. And when I say data poor, is they don't often sit with the aggregate of the data to figure out, what's happening in a consistent way and so on. And I think that's a dysfunction of the system. The doctor should be as empowered as the funder, and there are all sorts of initiatives to try and remedy that. But the data asymmetry results
with
in...
With 2.5 minutes left on the call, you throw that bomb into the call. We're going to have to unpack that one. I think there's a lot that needs to be unpacked there. But don't dive too much in it. You've got 2.5 minutes, so try and wrap up here, JG.
So I believe that there's this magic moment when a doctor is and it's not I believe, I've seen it, where when a doctor is administering drugs to a patient, it is the doctor is fully engaged, and there's just an incredible moment. We call it that kind of magic 30 minutes that's happening, or 15 minutes that's happening. And so invariably the drug that's being administered to a patient is the right drug. Should that drug be administered continually over time, that's sometimes a deficiency of the data. Sometimes the doctor is administering acute when it should, in a chronic sense, because the patient just keeps coming back. I do think there are opportunities for a greater level of visibility to empower the doctor better, so that maybe they should or shouldn't be able to, determine when they're using that drug. But I don't think anybody should ever be in doubt that the doctors, when a doctor is administering or prescribing drugs to a patient, that is the right choice to be done.
Sure.
But what you find is the patient doesn't often always comply with the way in which the drug needs to be taken. They don't complete the course. There is this self-empowerment of the person taking the drug, the patient, that can help the doctor and therefore help themselves over acute, chronic, mental. And so if there's my overarching summary of tonight's call, is the patient has the ability to empower themselves, to be aware that there are different types of treatment, chronic, acute, and everything in between, and learn about what your body wants from, learn what works best for your body. Empower yourself every single time you see the doctor, every single time you take a drug. Know whether it's working for you, whether it's not. I just want to encourage that each of us should empower ourselves.
Well, JG, I'm going to stop for half a second and say thank you so much for tonight. There is so much for us to unpack. It's going to cut off shortly. But for me, I really found this incredibly interesting. And certainly the last bomb that you dropped on us needs to be deliberated. So if you're happy, I'll have you on for, specifically